Our next speaker is Dr. Alvin Roth, Nobel Laureate from Stanford University. He doesn't need much of an introduction, but I will say that I am honored that he's here. And throughout my professional career in this latter period, he has just been an inspiration and a tremendous help in all matters like this. Dr. Roth, you have the floor.
Thank you. So I'm not going to talk about payments for kidneys, but I'm going to talk about some of the things we can do while we wait for human organ transplantation to no longer be necessary, or for the shortage of organs to be resolved. So here's the National Organ Transplant Act of 1984. So the law in the United States that forbids the payment to donors. And it uses a somewhat complicated phrase. Valuable consideration is what you can't transfer for use in human transplantation. I'll come back to that. But what I want to tell you about in the meantime is that there are a lot of practices today that we do in transplantation that at one point were taboo, were repugnant in some sense. But as we've gotten used to them, we've expanded the scope of transplants. So it's not just the law against paying donors that is a barrier to some transplants. Let me tell you some history. The first successful organ donation of any sort was a kidney donation in 1954 between identical twins. And the reason identical twins were important in 1954 is we didn't know much about the human immune system and what causes rejection reactions. So identical twins, the kidney from an identical twin doesn't inspire the immune system to reject it. So by 1990, though, a lot of progress had been made in immunosuppression to allow people to take organs. And in fact, Dr. Murray, the surgeon in 1954, won the Nobel Prize for his work in advancing immunosuppression and making kidney transplants more available. But still, in 1990, the World Health Organization said that adult living persons may donate organs, but such donors should be genetically related to the recipient. So that was a little bit of a carryover from the days when it was hard to overcome the immune reaction. But it was also something like an ethical stricture. They felt that the people who should be saving someone's life were the person's relatives. And partly that was due to their concern that donors shouldn't be paid. And they thought that maybe relatives were a good bet of people who would want to save a patient's life without being paid. But by 2000, the attitudes towards donors had expanded quite a bit. And here's an article that says many transplant centers break with tradition and accept spousal donors. So spouses, of course, care about the health of the patient, but aren't genetically related. But the immunosuppression was sufficiently advanced that wasn't a significant problem. And around the same time, here's this article in 2001 that says many transplant centers have started programs utilizing living unrelated donors, such as spouses, but widespread acceptance of such unconventional donors has not occurred because of the difficult ethical issues. So they worried that somehow your friends shouldn't be allowed to donate to you. This is a repugnance that we have since overcome, and I'll talk a little about that. And an even more difficult ethical dilemma, it says, arises if the donor happens to be a stranger. Thus far, the use of altruistic strangers has been considered to be an impenetrable taboo. So they're talking about non-directed donors who want to give a kidney but don't have a particular recipient in mind. I don't love the phrase altruistic in that context because anyone who donates a kidney is pretty altruistic. But these are non-directed donors. They don't have a particular recipient in mind. We use them a lot today, although it's still repugnant in large parts of the world. Lots of Europe where there's active transplantation still doesn't allow non-directed donors. They're not allowed in India, where there's a fair amount of transplantation. So that's still an ongoing issue. But as I'm going to explain to you, in the US, we really benefit a lot from allowing non-directed donors. So the way we benefit, and by expanding who can be a donor, is because of the fact that sometimes someone is healthy enough to give a kidney to the person they love, but the kidneys aren't compatible. So here's a simple picture of that sort. There's two patient-donor pairs, and donor one loves recipient one and would like to save her life and give her a kidney, but they have blood type incompatibilities. That's a kind of incompatibility that can be overcome in some ways now, but there are many kinds of incompatibilities. And donor two and recipient two are in the same situation. Donor two would like to give a kidney to recipient two, but they're incompatible. But what you can see from the picture is we need a blood type A kidney and a blood type B kidney, and they're both available in the picture. So we can do a kidney exchange, which is an exchange of kidneys that allows each patient, each recipient, to get a compatible kidney from the donor, the intended donor of another patient, of in this case, the patient in the other pair. Okay, so this was also a controversial idea. Kidney exchange today is still illegal in Germany, except in very exceptional circumstances with the intervention of a judge. But how about in the US? Remember, I just showed you the National Organ Transplant Act, and what it said was, it didn't say you can't pay a donor. It said it's unlawful for any person to transfer any human organ for valuable consideration for use in human transplantation. So when we look at the picture of kidney exchange, it looks like something valuable is being exchanged. Is that valuable consideration under the terms of the Act? And we started ramping up kidney exchange in the US at the beginning of this century, but the Justice Department wouldn't write us a memo saying that it was legal. So eventually, though, Congress stepped in 2007, and they said that sentence about valuable consideration does not apply with respect to human organ paired donation. And paired donation is a term of art that's meant to get the word exchange out of kidney exchange, so it doesn't sound like valuable consideration. And this is an amendment of the NOTA, of the National Organ Transplant Act, that says that kidney exchange is legal in the United States. And I'd just like to point out that the Norwood Act passed without any dissenting votes in either the House or the Senate. So first of all, that means that kidney exchange isn't legally repugnant in the United States. And second, it means that there was once a time where the House and the Senate could agree on things across party lines. And perhaps along with solving the problems of organ transplantation, maybe we'll solve the problems of bipartisanship one day. So we get a lot of use from non-directed donors. And the reason is that they solve a congestion problem that happens when we do exchanges just between pairs. So here's a picture of an exchange between two pairs. And we always do these simultaneously for reasons that I'm about to explain. And to do that, let's suppose that we didn't do this exchange simultaneously, and that on day one, donor two donated to recipient one, with the plan that on day two, donor one would donate to recipient two. But suppose that in the intervening days, something happens and donor one fails to donate to recipient two. That really harms pair two, donor two and recipient two, because they've had a surgery that didn't help them, and they no longer have a kidney with which to take part in kidney exchange. And so to make sure that bad outcome doesn't happen in the US, we always do these pairwise exchanges simultaneously. And that means that to do that simple exchange, we need lots of resources. We need 4 simultaneously available operating rooms and surgical teams for the 2 nephrectomies and 2 transplants. So that means it's hard to scale up. It's hard to do this, to do lots of transplants on a national scale. But when we have a non-directed donor, we can do something different. We can start a chain in which every pair gets a kidney before they give one. So in this picture, the non-directed donor on day 1 gives to recipient 1. And on day 2, unfortunately, for whatever reason, donor 1 fails to give a kidney to recipient 2. That very seldom happens, incidentally, but to keep the pictures comparable, that's the risk where we might worry about. And you notice that that's very disappointing if donor 1 isn't able to give a kidney to recipient 2. But it's not tragic, because pair 2 hasn't given a kidney yet. They still have a kidney, and they can take part in a kidney exchange tomorrow. So the risk of a broken link is much less when we have a non-directed donor who doesn't have to get a kidney in return. And as a result, we can have non-simultaneous exchange where each pair gets a kidney before they give one. And we can have long exchanges, as I'll show you in a moment. And this was also controversial. the proposal for this was in a paper in 2006, but the first non-simultaneous exchange that was conducted wasn't reported until this 2009 article in the New England Journal of Medicine. The hero of this story, incidentally, is the first author, who's Mike Reese, who's a very innovative transplant surgeon who's spent a lot of time thinking about how we can increase the availability of transplantation. And that first chain looked like this. The picture on the top is the picture that appeared in the New England Journal of Medicine article, and the picture on the bottom appeared in People magazine when most of the participants had stepped out from behind their HIPAA protections and allowed themselves to be identified. And you see that there are 20 people in the picture, 10 nephrectomies, 10 donations, and 10 transplants. And so when you can do chains non-simultaneously, they can be quite long. And just incidentally, this first chain, we didn't know exactly what we were doing, and it ended in this picture with a donor of blood type AB, which means that she can only give to a recipient who is blood type AB. And blood type AB patients who are in kidney exchange tend to have other obstacles of receiving a kidney. Otherwise, they would have received a kidney from their intended donor. So in fact, it was 3 years before a suitable recipient was found for her. She was still game and donated her kidney and added another 12 people to the picture. So exchanges can be quite long. And here's one that was the longest at the time in 2012. This is a picture from the New York Times. And there are 60 people in this picture, 30 transplants and 30 nephrectomies. So non-directed donors starting chains of transplants have proved very valuable for increasing the number of transplants we can do in the United States from living donors. Because before we had kidney exchange, if someone wanted to give you a kidney but was incompatible, the donor was sent home and the recipient had to remain on the waiting list, the long, dangerous, difficult waiting list. But now I can show you, I can show you some of the progress of kidney paired donation and non-directed donation transplants. So in blue and in red in the United States, from 2000, when we had the very first one, actually this graph just goes through 2019. And what you see is about 20% of the living donations that we do in the United States, there are not quite 7,000 of those a year, are done through kidney exchange and non-directed donor chains. So this is powerful, but it's not nearly enough to take care of all the patients who need transplants. And so we can think about how can we keep kidney exchange growing, since, at least in the US, kidney exchange isn't repugnant. We're allowed to do it. Okay. And one possibility, of course, is to combine, to coordinate the deceased donor process with the living donor process. And so here's a paper with some of the speakers today. I think John Roberts is going to be here, and Mike Reese is the last author. He's the guy who did the first simultaneous chain that says, maybe we could start some of those chains with carefully chosen deceased donor kidneys. And that's something that still is slowly going through the approval process at UNOS and in the US government. But it's taken off in Italy. Let me show you a recent paper from the Italians. Notice there's a picture of what's going on, and it's just a non-directed donor exchange where the initial non-directed donor is a deceased donor. It's a deceased donor kidney that goes, instead of going directly to the waiting list, it goes to a recipient in a patient-donor pair, whose donor passes it forward to another recipient, whose donor passes it forward to another recipient in a patient-donor pair, whose donor gives it back to the waiting list. Okay, to someone who was waiting for a deceased donor kidney. So the waiting list is not deprived of this deceased donor kidney. On the contrary, someone on the waiting list gets a living donor kidney, which lasts longer. And what the Italians report in this paper, which came out in Transplant International, is that with 8 deceased donor kidneys, they were able to do 24 transplants. So triple the number of deceased donor kidneys employed. So normally a deceased donor kidney, when it's successfully recovered and transplanted, provides 1 transplant. But these 8 kidneys on average provided 3 transplants each. And you can see in this picture the 3 transplants. So that's a way of increasing the scope of transplantation that doesn't seem to arouse repugnance, although it's arousing bureaucratic delay in the United States. But let's think a little more broadly. I've been telling you about the United States, but kidney failure isn't just a problem in rich countries. If anything, it's a much worse problem in middle income and lower income countries. Here's an article from The Lancet in 2015 that estimates that between 2 and 7 million people die every year worldwide due to financial barriers to dialysis and transplantation. So, in the U.S., we talk mostly about how there aren't enough organs, but transplantation is expensive, and in many parts of the world, kidney failure is a death sentence. And so, one question is how can we think about that in the context of kidney exchange? So, here's a graph that talks about the donations per million population, deceased donors, that's in blue, and living donors, that's in orange. And you see in the US, we have substantial numbers of both deceased donors and living donors per million population. There are other countries that do very well by that measure, like Israel. But Israel is a very small country. I'm going to show you that in a minute. So they don't have lots of transplants. China does poorly by the per million population statistic, but of course, China has many millions. So one of the things about these countries, particularly small countries, but even countries as big as the US, is our kidney exchange pools, our pool of potential donors, sometimes isn't big enough to find kidneys for our most highly sensitized patients, for the patients with the most antibodies to human leukocyte antigens and whose immune systems are least able to accept a kidney. So for those patients, finding a kidney is like finding a needle in a haystack. And the question is, where should we look, and what can we do to ease this? So here's a picture, not by per million population anymore, but by total transplants. And you see the US, which has high per million population transplants, also has high transplants of both deceased and living donors, a big pool of transplants. China, which doesn't have so many per million population, has a lot of transplants. The third largest number of transplants are done in India, almost all living donation. The fourth is Brazil. But countries like Mexico and Israel, which have perfectly capable hospitals, can do transplants, don't have many. And in particular, Mexico doesn't presently have kidney exchange, and Israel, which has kidney exchange, has a population of only 10 million. So they're not easily able to find exchanges that give transplants to highly sensitized patients. So one thing we can do is we can invite people into the big pool that we have in the US to take part the same way Americans do in American kidney exchange. And that will be a mutually beneficial arrangement, because the more people you can, the bigger pool you have, the more chance you can find kidneys even for the hardest to match patients. So here's a picture of a kidney exchange chain that involves a Mexican pair. The Mexican recipient is in the yellow dress in the picture. Her name is Marisol Robles. And she's in the middle of this. She's in the gray bar. Her pair, she and her cousin, are in the middle of an American exchange. They get she gets a transplant. Let me tell you a bit of background. She had a transplant in Mexico, but lost it, and is highly sensitized. So Mexico doesn't have kidney exchange. She was likely to die on dialysis, but came to the United States and took part in this American chain. And I have to remember to advance on my app, not on. Okay. Now, here's a paper with Mike Reese as the first author that talks about the financial barriers that getting a kidney from Marisol Robles in the United States has. So, what kind of financial barriers? Well, Mexico, as I showed you, has good hospitals that can do transplants, and they have several kinds of national health insurance that cover transplants within Mexico. But they didn't have a kidney within Mexico for a highly sensitized patient like Marisol. And the Mexican health insurance does not pay for transplants outside of Mexico. But what with the kind of financial accounting that Dr. McCormick told us about just before, the kidney exchange can be self-financing because Marisol and her cousins' participation in the chain allowed a highly sensitized American to be transplanted and taken off dialysis. And every time you take someone who was going to have a long time on dialysis off dialysis, you save enough money to finance the marginal cost of paying for the transplant for the Mexican patient. So Marisol's care in the United States was paid for by American funders. And then she went back to Mexico, where the good Mexican health insurance takes care of her and her donor in recovery. So this sounds like a good thing, but not everyone thinks it's a good thing. Here's the director of the Spanish ONT, the National Transplant Organization in Spain, saying that the ONT prevents the entry into Europe of a new form of organ trafficking proposed by a winner of the Nobel Prize in Economics. That's me, apparently. And she goes on to say, I have translation on the right there. She says that it's really a veiled sale of organs. So she says this is organ trafficking because by treating a foreign patient who didn't have good health insurance in the United States as an American and having her transplant and care and her donors nephrectomy and care paid for by American funders, that's the same, is the view from Spain, as organ trafficking. And the reason, their argument, is that we couldn't possibly have been interested in saving the life of a Mexican family, a patient-donor pair. So it must be that the only motivation was to exploit the Mexican pair for the help of an American. But of course, that's not the way it looks in Mexico. So here's Newsweek on Espanol, the Mexican version of Newsweek, and they ran a cover story which appears on the cover, and it says "Un puente de vida," a bridge of life. That transplants between the United States and Mexico are a bridge of life. And there's a paragraph in there that says, just as U.S. President Donald Trump is seeking to build a wall of thousands of miles on the border with Mexico, a tireless surgeon and an economist joined forces to exchange organs between citizens of both countries. So the view from Spain and the view from Mexico on whether it's valuable to save the life of a Mexican patient are quite different. And in general, this metaphor of a bridge works in other exchanges across borders as well. Here's an article in USA Today about a kidney exchange between Abu Dhabi and Israel. I went to Abu Dhabi in this connection in the summer of 2021, and in the photograph here, you see Tamar Ashkenazi, the director of the Israeli Transplant Service, with a kidney coming from Israel. Here's the whole panoply. Mike Reese is on the right. There's a kidney from Israel and a kidney from the UAE, and Dr. Ashkenazi flew in to Abu Dhabi with the Israeli kidney and flew out with the Emirati kidney. And it's a three-way exchange. Each of the recipients is a mother who was sensitized to paternal HLAs in the course of childbirth and was highly sensitized. The three pairs were an Arab-Israeli mother and her husband, so an Arab-Israeli wife and husband, a Jewish-Israeli mother and daughter, and the pair from the UAE is a mother and daughter who want to be identified only as Arab residents of the UAE. So that was an exchange that couldn't happen within the countries because both Israel and the UAE only have populations of 10 million, and that gives you too small a kidney exchange pool. But working together across borders, they were able to get this exchange going and also strike a blow for peace. And fortunately, as people have come to understand global kidney exchange, it's gotten support. So it's gotten support from the American Society of Transplant Surgeons. There's a lovely article in The Lancet by some colleagues of Dr. Ratcliffe Richards. I think Julian Savulescu in particular is at Oxford. And they consider the arguments against global kidney exchange and say it's been accused of being a form of organ trafficking, exploiting the poor, and involving coercion and commodification. We refute these claims, arguing that global kidney exchange promotes global justice and reduces the potential for people in need of kidneys in low income and medium income countries to be exploited. And what they have in mind there is that increasing the opportunity for legal, safe, ethical kidney transplantation deprives the black market of some of its demand. And as Dr. Sharfuddin remarked at the beginning, some of these black markets are pretty nasty. Black markets run by criminals where the patients come back to their regular doctors with opportunistic infections because the transplants weren't performed in sterile conditions. So increasing availability of kidney exchange is important, and so is it important to. It's also important to fight illegal black markets run by criminals that do a bad job of medicine, and global kidney exchange helps in both of those dimensions. Similarly, here's an article from Transplant International written by a committee of the ethical, legal, and psychosocial aspects of transplantation of the European Society of Transplantation. And they issued a report which says, among other things, it's doubtful that GKE violates the non-payment principle and that it's not exploitative. So we're seeing increased acceptance of kidney exchange, not just domestically in the US and in some other countries, but across borders. And I think that's a very good thing. It's an encouraging thing, but it has faced a lot of hesitation. So thinking about the future, when we can think about kidney exchange as a global activity, I was in Ahmedabad in 2019. I got to sit in on a kidney transplant being done robotically in a Da Vinci robot. So the surgeon who you see with his back to me in this picture hadn't scrubbed in. When I came in, he got up and shook my hand, and neither of us were wearing gloves. And the reason is he's not touching the patient. The patient is off to the side being tended to by people in the sterile field. So although this transplant was done very close to the patient, you can start to imagine that surgeons might be able to conduct surgery at more distance. And as we talk about increasing the pool through which people can get kidneys, that seems like an intriguing possibility also. So this is my last slide. Kidney disease is a global problem, and kidney exchange is a naturally global market. Economists speak of markets as being thick, and what we mean for kidney exchange is that if someone needs a transplant and is highly sensitized, it's hard to find a compatible kidney for them. It helps if they can look in the widest pool possible. And so hard to match patients need a big pool of potential donors. The medical technology is available around the world, and the global connectivity and the data and computer-assisted markets can help organize globally inclusive kidney exchange. And every time we make safe, legal, ethical transplantation available to someone, we're subtracting demand from the black market. So it's a win-win solution. Thank you.
Thank you, Al. That was a wonderful presentation. I hope you realize that you should be up for a second Nobel Prize, at least the Peace Prize, I would think. But anyway, thank you very, very much. Our next speaker is Dr. Frank McCormick, cost-benefit analysis of rewarding kidney donors. Dr. McCormick has been working on this for quite some time. His very powerful article on this very topic has just been accepted by Value in Health, a leading health economics journal. Without further ado, Dr. McCormick, you have the stage.
Hello, everyone. My name is Frank McCormick. In his introduction to this symposium, Professor John Fung pointed out that the shortage of transplant kidneys for kidney failure patients keeps getting worse, not better, especially for low-income and minority patients. That is, we are losing the war against kidney failure. Over the past 8 years, my co-authors and I have written a series of articles arguing that the way to win this war is by having the government reward kidney donors. Our most recent article, which is forthcoming in Value in Health, a major health economics journal, carries that argument to its logical conclusion by asking what level of government compensation would be sufficient to encourage enough qualified kidney donors to completely end the kidney shortage. That would be particularly beneficial to low-income and minority patients, since enough transplant kidneys would then be available for all patients who need one. We estimate that compensation somewhere in the neighborhood of $77,000 per donor would completely end the kidney shortage and save more than 40,000 kidney failure patients a year from suffering on dialysis and dying prematurely. That's right, more than 40,000 patients every year. Here is our argument. 3 years ago, my co-authors and I wrote an editorial for the leading nephrology journal, arguing that the kidney shortage problem is much more serious than is generally realized. This slide illustrates that argument. The height of the column shows the number of patients diagnosed with chronic kidney failure in the U.S. each year, which is roughly 124,000 patients. Of that number, only about 22,000, the 18% shown in green, receive the optimal treatment for kidney failure, which is a kidney transplant. These fortunate 18% get to live an average of 10 to 20 years in reasonably good health. What happens to the other 100,000 plus kidney failure patients, the 82% shown in red? They are fated to suffer on dialysis for an average of 4 to 5 years as their health steadily deteriorates until they die prematurely. We call them the forgotten patients because almost no one talks about them. Who are these forgotten patients? They are disproportionately poor and minorities. For example, income and educational level are highly correlated, and people who have not finished high school make up 34% of new kidney failure patients, but only 5% of those who receive a kidney transplant. Similarly, Black people in the U.S. are 3 times more likely to develop kidney failure than white people, but are significantly less likely to receive a kidney transplant. The crucial question is, how many of these 100,000 plus kidney failure patients could be saved by transplantation from a premature death if there were no kidney shortage? No one knows the exact answer to that question, but on the basis of the limited hard evidence available and considerable anecdotal evidence, mainly from nephrologists, we estimate at least half of the 124,000 patients diagnosed with kidney failure each year could be saved from premature death if there were no kidney shortage, about 62,000 patients. Since only about 22,000 patients are now receiving a transplant, that means more than 40,000 kidney failure patients are dying prematurely each year because of the kidney shortage. 40,000 deaths a year is a lot of deaths. That's equivalent to 80 fully loaded 747s crashing each year. It is 110 deaths per day. It is 1 death in the 15 minutes it takes me to give this talk. The previous slide showed the data for a single recent year. This slide, which is from our editorial in the leading nephrology journal 3 years ago, shows the same data year by year going back to 1988. The top red line indicates 50% of patients diagnosed with kidney failure each year. The bottom line shows the number of patients who received a transplant in that year. So the difference between the 2 lines, the vertical bars, indicate the number of kidney failure patients who suffered on dialysis and died prematurely due to the kidney shortage. When we added up the vertical bars 3 years ago, we found the total number of premature deaths since 1988 due to the kidney shortage was approaching 1 million deaths. and we forecast that over the next 10 years, the number of premature deaths because of the kidney shortage would approach 500,000. Tragically, that forecast is turning out to be accurate. If we add the data for the past 3 years, the total number of premature deaths since 1988 has risen to about 1.1 million. That is not an 800-pound gorilla in the room that everyone is ignoring. That is an 8-ton Tyrannosaurus Rex that everyone is ignoring. What can be done to reduce this appalling death toll due to the kidney shortage? We can end the kidney shortage by having the government compensate living kidney donors. Many researchers have argued that the government can substantially increase the number of kidney donations and transplants by compensating living kidney donors. Our study extends that line of reasoning to its logical conclusion by asking what level of government compensation of living kidney donors would be necessary to encourage enough donations to completely end the kidney shortage. That is, to save from premature death half of those diagnosed with kidney failure, about 62,000 patients per year. In this brave new world in which there is no kidney shortage, each of these patients would be able to receive not only a first transplant, but also second and third transplants if their previous transplant fails. On average, we estimate that 62,000 kidney failure patients would receive about 1.5 transplants each by age 75. So a total of 93,000 transplants per year would be necessary to save the 62,000 kidney failure patients per year from premature death. Since about 22,000 kidneys are already being donated each year, we would need an additional 71,000 donated kidneys per year. But what level of government compensation of kidney donors would be necessary to induce these additional 71,000 donations per year? We addressed this question in Supplement 2 of our study using supply and demand analysis. We concluded that compensation of roughly $77,000 per donor would be sufficient to induce the required 71,000 additional donations per year. However, a wide band of uncertainty surrounds that estimate because we are entering an area where there is a paucity of empirical evidence. Fortunately, this does not present a serious problem for our analysis, since the level of compensation is very small compared to the huge benefits for recipients and taxpayers. The next step in our study is to input the results from our supply and demand analysis into a detailed cost-benefit analysis. Column 1 of Table 1 shows the benefits and costs for an average kidney failure patient receiving a single kidney transplant at the current time when donor compensation is prohibited. Starting with the benefits. The top line shows the value of the lifetime gain in economic welfare for a single recipient and their caregiver is $1.1 million. The second row shows the lifetime savings from a kidney recipient not needing expensive dialysis therapy, including associated hospital costs, $1.2 million. Turning to the costs, row 3 shows the cost of the transplant operation itself, $133,000. Row 4 shows compensation to a kidney donor is zero because it is currently legally prohibited. Row 5 indicates the medical costs after the transplant for the lifetime of the recipient, $531,000. Row 6 shows the net welfare gain for society, which is just the benefits minus the costs, $1.6 million. The addendum item at the bottom of column 1 gives the savings to taxpayers over the life of the kidney recipient, $416,000. Now turning to column 2 of Table 1, this shows the same information, But for the case where the government compensates living kidney donors $77,000 per donor, which ends the kidney shortage, enabling the average kidney recipient to receive about 1.5 transplants. Note that the value to the kidney recipient and their caregiver from receiving an average of 1.5 transplants has increased to $1.5 million. Note also that even though living kidney donors are now being compensated, the amount of compensation is very small compared to the increase in welfare for the recipient. So the net welfare gain for society increases to $1.8 million. The final step in our cost-benefit analysis is to multiply the outcomes for a single kidney recipient, which we just saw in Table 1, by the number of recipients before and after the government compensates donors, as shown in Table 2, columns 1 and 2. Column 1 of Table 2 shows the current situation in which there is virtually no government compensation of kidney donors, and consequently, there are only 22,000 kidney transplants each year. Column 2 of Table 2 shows the situation after the government compensates living kidney donors $77,000 per donor. The resulting 93,000 transplants would be sufficient to provide 62,000 recipients with 1.5 transplants each. Column 3 of Table 2 shows the net benefit from ending the kidney shortage. It is just column 2 minus column 1. The most important result is in the second row. 47,000 additional kidney failure patients each year would avoid suffering on dialysis and premature death, and instead would live significantly longer and healthier lives. Also, the net welfare gain for society would increase by $86 billion per year, and taxpayer savings would increase by $7 billion per year. That last point is particularly noteworthy. In addition to saving lives and increasing the welfare of society, compensating living kidney donors would also save money for taxpayers. This is because the savings from not having to pay for expensive dialysis therapy exceeds the cost of transplantation. This final slide summarizes our argument in favor of compensating living kidney donors. More than 40,000 kidney failure patients die prematurely each year because of a shortage of transplant kidneys. The government could end the shortage and save those lives by compensating living kidney donors somewhere in the neighborhood of $77,000 per donor. The value of this policy to each kidney recipient and their caregiver would be about $1.5 million. The value to society would be about $86 billion per year. Taxpayers would save about $7 billion per year. This cost-benefit analysis reveals the huge benefit in terms of longer and healthier lives that government compensation of kidney donors would provide to kidney failure patients and their caregivers. Conversely, it reveals the huge cost that is being imposed on these patients by the current legal prohibition against such compensation, about 110 deaths per day. It is stunning to realize that had this policy of preventing a kidney shortage by compensating living donors been in effect for the past 33 years, it could have prevented the premature deaths of over 1 million kidney failure patients. Some people may find the idea of compensating kidney donors to be repugnant, but is it more repugnant than allowing 47,000 kidney failure patients to die prematurely each year? That is the choice we face.
Thank you, Frank. Thank you very much. Excellent presentation. Our next speaker is Cody Maynard, who is, by the way, a living kidney donor. And I might note we have 4 people participating in this program who are living kidney donors, and by and large, non-directed living kidney donors. At any rate, Cody is an independent living donor advocate. He comes to us from his work with NKDO, the National Kidney Donation Organization, which was also very generous in helping to support this symposium. Cody, the floor is yours.
Thank you for that introduction, Philip, and thank you, Dr. Roth, for that amazing discussion right before this. For those of you who do not know me, my name is Cody Maynard, and I'll be giving a talk today on immediate actions that we can do to increase the pool of living donors. Awesome. I wanted to give a brief overview of our NKDO team. We have a really talented executive team that oversees 60 donor mentors, all of whom are living donors, as well as certified AST independent living donor advocates. And we work across 17 different transplant centers to help facilitate donors through the donation process. An overview of NKDO's mission and key priorities. Really, we want to help eliminate the wait list for kidney patients. And we want to educate prospective living kidney donors and ensure that they have informed consent about their decision to donate. And that includes also removing the disincentives to donate. We do that in a threefold approach. First is providing key education, both through media outreach, PSAs, distribution of education material, as well as advocacy through both state as well as federal regulation. And then we enjoy building communities within both the donation, or the donor, as well as recipient pools. I think we've had a lot of great discussion today on the possibility of potential strategies to compensate donors in the future. But what we want to focus on right now is immediate strategies we can do to increase the pool of living donors. And largely, our strategy is focused around ensuring that donors as well as their recipients have access to both the protections as well as the support services. And so there's two different levels to this. First is what's available on a federal level. So there are assistance centers such as the National Living Donor Assistance Center, which provides sort of baseline offerings of different support services, as well as the great exchange networks that Dr. Roth was talking about previously, namely the Alliance for Paired Kidney Donation and the National Kidney Registry, which offer a swath of different donor protections as well as recipient support services. And just a side note, if these education materials are sent out after the discussion today, you can actually click on each one of the icons here and it'll bring you to a detailed appendix slide to inform you more about that offering. So I'll walk through each of these different components quickly. The first, as I mentioned, is the National Living Donor Assistance Center, which provides different baseline protections for donors, namely travel expenses, lost wages, as well as dependent care expenses. One item of note here is that NILDAC does means testing of the recipient, which we believe is a bit of a perverse incentive if you have a wealthy recipient but an unwealthy donor, and thus the donor is not eligible for some of these support services because their intended recipient is wealthy. And obviously there should not be a transfer of wealth between the recipient who is wealthy and the donor who is non-wealthy. So I definitely think there's some modifications to the administration of this program, definitely. Moving on to the next slide here, talking about the national exchange networks that Dr. Roth was focusing on. The Alliance of Paired Kidney Donation is an exchange network offered in around 30 different centers here. They have lost wage reimbursement, different travel and lodging reimbursement, as well as insurance for both the donor and their support companion, as well as a kidney pledge. And this is offered to non-directed donors who participate in a non-directed donation through the Alliance of Paired Kidney Donation. And the Alliance has said, if you donate your kidney into our pool, then we will ensure that you have a living kidney in the future should you ever need one. There's also a National Kidney Registry, which also provides protections and support. I'll go through a couple of key items here. The first is related to that kidney prioritization for a living kidney should they need one in the future. This is both available for non-directed donors as well as donor pairs, where the donor participates in an NKR swap. There's also a voucher program similar to the APKD pledge if there's a family member in need. But also they do a standard voucher if there's someone I know who needs one in the future, then I can donate now, and they can get a voucher to receive one in the future. They also have donation insurance, complication protection, as well as offer legal support services to ensure that there's no wrongful termination or your health insurance premiums are not increased. And then one crucial item that I do want to highlight here is that donor mentorship. So if a potential donor enters into the National Kidney Registry database as a potential donor, then they receive the opportunity to speak with a living kidney donor who is ILDA certified and can basically discuss the personal experiences that they went through and provide any sort of coaching or advice. Aside from the actual donor protections, I do want to highlight the NKR recipient support services. So, namely, the NKR does a wonderful service called a patient microsite, which is a customized website that the patient can fill out with help from their transplant coordination team in order to have their own personalized website that they can share on social media. They have business cards that they can distribute with the links associated with that. Any potential donor who goes to that site and would like to donate, they can click on I'm interested in donating to Jane Doe, and their information will get plugged in directly into the NKR system. Through that, they also offer donor search expert coaches. These are individuals whom have led kidney search campaigns in the past, either as the recipient or a patient champion or a donor themselves. And they really identify key strategies for the donors for their recipients to find an intended donor. And then they also offer different champion training to basically coach their different family members or anyone who is assisting them in their search for a donor on key strategies to actually find a donor. So this next slide here is just a brief overview of what's offered at different types of centers. But I just wanted to wrap us up with the conclusion of those key elements that we discussed. So the donor protections that are offered, the recipient services, we believe that it is absolutely critical and a sine qua non of informed consent that donors and their recipients have the knowledge of the different offerings that are offered by these national exchange networks, and that can be done through education and awareness promotion or different care coordination through the transplant centers, their health plans, nephrologists, and their own personal network. I really appreciate the time. Apologies for any technical difficulties. Thank you so much. Look forward to your questions.
We're now scheduled for a discussion period. Dr. Arthur Maynard will be the coordinator of that. Dr. Maynard, I know, previously expressed interest in asking questions of Dr. McCormick. I think, Dr. McCormick, yes, you are in the green room. And Dr. Maynard, I know you were asked about questions, and I'm really looking at the questions from the audience, and there isn't much that I could feed to you on that. Dr. Maynard, you have the floor.
So let me start with Dr. McCormick and ask about the error in these calculations. I mean, $70,000 is a specific number. What's with a lot of calculations going into it? Where is the range, if you will?
It's can you hear me here?
Yep.
Yes.
Okay. Okay, there's a very big range. It's very uncertain about what the price will be, but it turns out that that is not very important because the price is so small compared to the benefits that accrue to the recipient and also to the taxpayer that it doesn't make much difference. You could readily say that the error is plus or minus 50%. So that would be taking it from $50,000 up to $115,000 or something like that. But it turns out that that is small potatoes compared to all the other calculations there. So although there's great uncertainty about that, it doesn't change the final conclusion that we would save an enormous number of lives. And that's the crucial thing here. There are lots of people dying unnecessarily because of the shortage of organs. And if we can do something to increase the supply of organs, then that will have an enormous beneficial effect.
Let me make a comment on that. One of my observations is working with opioid costs and so forth. I was saying earlier that I've been working to try to have them introduced into their vocabulary value. I mean, when people are focused on cost in this organ procurement business, I mean, Frank just gave an explanation of why, whether it's $70,000 or $50,000 or $150,000, is small potatoes in this when you take into account the value of these things. It's kind of strange that we economists are telling you doctors that you should be taking value into account.
So a question for Dr. Roth, and one of the issues with the global exchange is the resources that are used. And one of the problems in the United States is access to transplant. And we know that socioeconomic status is a huge barrier to access for transplant. There are many people actually turned down by transplant programs because even with Medicare, Medicaid, they don't qualify and they don't meet criteria for being able to, say, support their medications. Has there been thought about using some of these resources to support those people? Because those people may, in fact, be the right person for your highly sensitized patient.
Absolutely. I think maybe you said earlier that we should be, maximizing every avenue of increasing availability of transplants, and I certainly agree. Mr. Maynard talked to us about NALDAC, the National Living Donor Assistance Center. I've been on their advisory board for a number of years, and when I joined, we were only allowed to very grudgingly give very small amounts of money to pretty poor people to cover travel and meals while traveling. And now we're also able to make a small contribution towards lost wages. And last year, our payments for lost wages were just about as large as our payments for travel had been. So there was a real need for that. So I'd be glad to see all the means gathered to support transplantation. And it's certainly true that poorer Americans have less access. NALDAC's budget comes from the Department of Health and Human Services. So they, so savings to Medicare, savings to the general American obligations to pay for kidney treatment. When we help get a transplant through NALDAC, it saves money for the general budget. So we can definitely afford, as Dr. McCormick says, we can definitely afford to be more generous on every margin.
But there's no program trying to really push that, correct? To provide resources for those deprived or socioeconomic disadvantaged people. Well,
there are certainly people interested in it, but they run into the barriers that paying, donors and in general runs into. For a long time, I think now fixed. You'll know better than I. For a long time, Medicare only paid for 3 years of immunosuppressive drugs after kidney transplant, and that's just
sorry, Al. Al, let me point out when it started, it was actually 1 year.
That's correct.
It started with only 1 year protection for drugs.
transplants and for dialysis would stop paying for some people's immunosuppressive drugs. Some of them would lose their kidney, and then Medicare would cheerfully pay for dialysis again, which is vastly more expensive. So it's not that decisions are being made in a rational way, even for bean counters. Even for people who had the personality to become accountants rather than economists. So we're doing a very bad job on a number of margins, as several people pointed out, and we should try to do better on all of them.
That's a particularly U.S. problem, of course, in the sense that and since countries that have universal health care don't have that problem. But there's no doubt.
Well, they still have to pay for dialysis, which is more expensive than transplantation. So they're paying for it, and economists talk about opportunity costs. I've been in discussions with various European regulators, and one of them, in all seriousness, said to me, here in Europe, kidney transplants don't cost anything. And what she meant was national health insurance pays for it. The patient doesn't pay out of pocket. But of course, the system pays a lot for it, and it pays a lot for dialysis. And they could do more medical care if they had less dialysis and more transplants. Right.
But systems with universal health care don't stop payment for medications at 3 years. I mean, this is a huge, or was a huge U.S. problem. Right.
Yes. So we have a lot of problems everywhere that are, I think Dr. Radcliffe Richards said something to that effect, is that there's just all sorts of funny dead ends in transplantation that could be rationalized in ways that would be safe and ethical and legal, but we don't do. And we might have to change some laws.
Dr. Matas. Okay, Dr. Matas, I have one question or one comment from the audience. Sorry, my microphone fell off. But before I give you the question, Dr. Roth, I'll tell you something. I did extensive study in cost in Europe, and this notion that this is free, et cetera, you get a very different response from patients as to what is free than what you get when you ask their doctors of this supposed pure healthcare system. Believe me, the costs are not zero. Dr. Maynard, from our former speaker, Dr. Asif Sharfuddin, he says, shouldn't we as a country and community offer all these protections to all donors, regardless of whether they go through KPD? I would think so, he says. Do you want me to repeat that?
That was actually a question I was going to ask Cody Maynard, is that you described these protections for some people, but clearly not for all. So is your advocacy group working to provide those protections, not only protections, financial support, et cetera? I mean, the NKR is doing a nice job now, but it's limited to certain transplant centers.
Yeah, so I would say the answer is twofold. The first thing is that the government cannot provide the protections such as kidney prioritization or a voucher that exchange networks such as APKD or the NKR can provide. The second thing is that I think when it's at a more localized or privatized level, where we have a independent group such as NKDO providing different donor mentorship services on either a exchange network basis or on a transplant center basis, I think that's a more effective strategy than someone going through some government agency to speak to some other person in the government who happens to be a donor. And then I would say, thirdly, I think the innovation that is created by these independent private exchange networks to say, we are going to create more protections and more service offerings to incentivize both the transplant centers to come into our network as well as the patients. That sort of innovation and competitive advantage that is built into that, I think, is a great form of providing and creating new incentives that perhaps, or new protections and support services that perhaps we have not thought of quite just yet.
Well, but you would agree that all donors although all living donations should at the very minimum be financially neutral, which is not necessarily universally provided. I think that was the question that was really being asked.
Sure, I think so, and to a certain extent, I mean, there's lost wages, travel expense reimbursement from a NILDAC perspective, so those should be available to all donors. But there are other services like different remote donations, legal support, home blood draws that are also offerings that we want to ensure are available to donors.
I'm afraid I have to interrupt here. We do have a 4-hour bound, which is a hard line. And so we're a bit behind here. So our schedule does call for a break of 10 minutes, but I'm going to ask you to keep it to 5 minutes, if you wouldn't mind. Thank you. And we will continue this discussion in 5 minutes. Thank you.